Okay, I think I can gauge from the comments in the chat that this has been a session that's been extremely well received. The good news is we do have a number of questions, but I will start in the order that I'm seeing them in the bar. And the first question is for Jean-Luc, please. And you have a question from Michael Pavon, who's asking if you could provide a little bit more description on how you're planning to apply your digital droplet PCR in clinical practice. Are you looking at oropharynx? Are you looking at cervix? So if you could expand a little on that, that would be great.
Thank you for this question. Actually, using droplet digital PCR is interesting for the follow-up of patients treated for HPV-associated cancers, and there are very nice publications in anal cancer, for example, and more recently on head and neck cancers, showing that the absence of detection of HPV-16 in circulating DNA is prognostic. Meaning prognostic predicts the good response to the treatment. And probably the next step will be the follow-up of patients after treatment, and probably that the detection of HPV in circulating DNA, so from from the blood directly, would inform of probable recurrence of the cancer. So this is what is this is what has to be done with droplet digital PCR. An opportunity to follow patients treated for HPV-associated cancers.
Indeed, it's an absolutely fascinating area, and I think we could dedicate a whole session to it. But thank you very much, Jean-Luc. Yeah. I'll move on from the laboratory type of question to a question which I might summarize from Eduardo, a very interesting point. In relation to the need to remove the incentive for co-tests, are some doctors asking for co-testing because they may not know that cytology will be done reflexively for those who are HPV positive? Perhaps if they were better edified, they would stop checking both of the boxes. Very good point, Christine.
Do you listen to me? Can you hear me?
Yeah, yes, we can hear you fine.
Yeah. No, they know very well, because it is written that if HPV is positive, we will do reflex cytology. So it is written. So they know very well. And the clinician know very well. No, the pathologist push the clinician to do co-testing for, we are going to say, conflict of interest, financial conflict of interest. We have to say it.
Okay. Remove the second box.
I agree, but we have no control on that.
And I guess if I can just follow on from a point from Margaret Stanley, who's joined us, I think this relates to your talk, Christine, again, is that nothing changes. Every innovation in screening and lesion management has been resisted by clinicians since I trained as a cytopathologist a long time ago. So a clear and unvarnished view from Margaret there.
Thank you, Margaret. And you know as well, they always take the example of Germany, because in France, we like to compare us with Germany. And they say, look, they ask always, do like their Germany, they are very good in everything. But, you know, in cervical screening, perhaps they are not the best. And they are proposing co-testing, and they take the example as well of US, where you can do co-testing. So it's very difficult to convince them with, of course, objective argument. We know it does not worthwhile to send the patient to colposcopy when she is ASCUS HPV negative, but they don't care. You know, there are big bias.
So we have some entrenched sentiments there that are non-trivial to try and navigate. We have a question from Sylvia de San Jose, however. Sylvia is saying, interesting point. Maybe it would be an opportunity to allow women to choose about self-sampling, providing they understand the benefits. Our work in Spain is of high acceptance when women are provided with good information. I guess I know that Christine's and the other speakers in the session didn't necessarily focus on self-sampling, but do you want to articulate your view at the moment about the importance of education and how that might play out in France, and what would be you kind of incentivizing things for women to explore that option?
Kate, I don't know if it's to me, but I wanted to respond to the point that Susan Kier made about the possibility to actively unsubscribe to the screening program. And I thought that was an interesting point, in a sense that women can have the opportunity to choose by themselves what they want. But to do that, they need to be well educated, and we need to provide fair information of what are the harms of doing co-testing, for example. What are the benefits of doing self-sampling at home and avoid the visit? So if we educate women, our experience here is that they do accept it and they like it, and they are more likely to have the regular coverage that we need to prevent cervical cancer. Thank you.
But maybe to add here also the question from the Xavier Bosch, because if you cannot disciplinate your doctors by recommendations, there is another way, and this is the actually reimbursement policy insurance companies. Because clearly for us, for example, we in Slovenia, we stop all this chaotic story once we decide that people who are not participating with the screening registry cannot be reimbursed anymore. And in 1 year we resolved all chaotic situations. So if the recommendations by colleagues and medical doctors are not working well, maybe you should try to just stop reimbursement, and this is the way how you can actually potentially put everything in order.
It's
a very interesting point, I have to say. By all means, Christine,
exactly what I say as a proposal in my concluding slides, but it's very provocative to do that in France, not to reimburse the test, because as it is a private system, in most of the case, the patient are going to say, we have the right to be reimbursed. If my doctor was performed the test, and the patients are under the control of their gynecologist. Really, we have no access to them directly. They are used to see their gynecologist regularly for 20 years, and they listen their message. It's really the first person they listen. So if gynecologists do not apply the recommendation, it's very difficult to have access to the patient.
Okay, thank you, Christine. I think Mario Eduardo has mentioned in the chat that disincentive is the solution. So there are some clear advocates for that approach, given the current situation.
Just to say, in our case, so the cost of cytology in Slovenia was only €7.
Right.
But, even with the €7, we were with a strong reimbursement policy. Actually, we switched very efficiently from opportunity to organized screening. And actually, we closed more than half of the cytology laboratories because they actually stopped to collaborate with the registry, and you cannot reimburse this. It was possible. I think it's possible in many countries. Yeah.
Okay, Christine, I think perhaps you still have challenges with your mic, but I see that you have put some responses in the chat, which is great. In terms of HPV screening between 25 and 65, you're saying yes, you would agree with Eduardo that would be easier. I guess further discussion would help as to whether or not how easy that would be to implement. And then there is a question that was asked about comprehensive biomarkers. And I think you're indicating that with respect to application of biomarkers for triage that didn't rely on cytology, it would still probably be at the research stage for some of the more innovative approaches that combine genotyping and methylation, for example, and that we may be some way before validation of a wide range. If that's a fair kind of summary of your comment, nod. But if not, then hopefully you'll be able to join us for the remainder of the meeting, and there'll be other opportunities to comment in the chat. And I don't know, I'm sorry, Alex, we've got 1 minute left, as I understand. There had been quite a lot of activity in the chat. I don't know if there are any questions on the floor from people. It's a little challenging for Mario and I to see that. So maybe we have time for one lightning quick question from somebody who's there, and an equally lightning quick concise response.
Okay, someone is asking questions.
I don't see any arms raised here for questions or. No,
yes, I've just put a question.
Oh, Margaret's
up.
put one in. Yeah, Margaret, by all means.
You've got so many private testing labs. How do you ensure quality assurance?
Margaret, very good question. The problem that they are, again, in private system, and there are no obligation to have quality assurance control from outside, of course. So for the clinical pathology, yes, they have to be accredited, but not anatomical pathology, as we call it for the cytology. And they do what they want. There are no obligation. Some of them, of course, we are accredited, our lab in cytology, but it's a choice. You have not to be. You can practice even if you're not accredited. So I think this meeting is quite a good opportunity to push some suggestion, and after it will be the choice of our state. You have seen so many agencies. They can now do things because I am very shocked by what is happening.
Yeah, just to say also what we did in Slovenia is the same story. So if you are not following a quality control and you cannot prove this, you cannot be reimbursed. That's it. This was our national policy. Very clear.
More easy to handle your population than yours. Ours.
Okay. Thank you.
It's a very good point, though, Christine. It's about being proactive and constructive, isn't it, as opposed to bemoaning the current situation. And perhaps there's capacity and bandwidth to be able to do that in the breakout sessions in session 5. Again, we can be guided on that later on. But I guess we are now at 51 minutes past. And so I would like to bring the academic component of this session to a close, unless Mario has anything else he wants to contribute, and commend all the speakers for such lively and thought-provoking discussion. Right.
Thank you.
Cheerio, everyone.
See you. Ciao.
Bye-bye.
Bye-bye.